Hello, good morning or good afternoon. My name is Dr. Vishwanath Dan Thuluri. That's Dan Thuluri in three parts, but you can call me Dr. D if that's easier. Thank you for coming to see me. Today you're probably here either as a consultation referral or through your own self-directed research and finding me in order to discuss your heartburn symptoms and what your options are for treating that. The objectives with this PowerPoint and our visit today is for you to leave here understanding what GERD actually is, the risks associated with GERD, risks associated with the common medications we use for GERD. What are the anatomic or your own inherent anatomy mechanical barriers to GERD? So I want you to understand how functionally you're set up to fight GERD, and then it'll make sense why we get certain studies to look at these things and see if something's wrong at a specific location to then figure out what surgery suits you. And then we'll go over the next steps, which is exactly what I was referring to, figuring out what studies need to be ordered and set up to make the best decision. If nothing else, and we don't proceed after this visit, I'm not offended. I hope you leave here today feeling educated about a common problem and knowing that you are empowered to make the best decision for yourself. And I'm here to guide you. Let's talk about GERD. Gastroesophageal reflux disease, GERD being the acronym, is what literally GERD means. And GERD or gastroesophageal reflux has to do with contents that are in your stomach, leaving your stomach and coming back into the pipe that's bringing food down to that stomach, so or the esophagus. So anytime something leaves, and particularly acid, which tends to be the main cause for symptoms, leaves your stomach and enters the food pipe, if you will, that's called gastroesophageal reflux. When does it become, quote, a disease? Well, once you've had it going on for long enough and frequently enough, that constitutes that clinical diagnosis, which we would write on paper, which is GERD. There are trigger foods for this. The most common one, and I bet you're nodding your head, as I say it, it seems to be tomato sauce or tomato-based products. I hear this one all the time. There's different ways that these foods cause reflux. Some of them, like cocoa, believe it or not, chocolate, a derivative of the cocoa tree breaks down into a chemical called methylxanthine, and this can actually go and act on a muscle we're going to learn a lot about to relax it, and it opens a door that otherwise should remain shut to prevent acid from coming back up here. So some things we get in our diet physically affect the acidity of what we eat. They open doors that should be closed. They create gaseous distension or high pressure in here. And some way, somehow, I'll just tell you that lifestyle and what you're eating repeatedly over many years is probably leading to a breakdown of the barriers, which we're going to go over in a minute, and we can revisit these later. Here's the common symptoms of GERD: heartburn, chest pain, gas, or bloating. Less common symptoms that sometimes lead to people going down a pathway of unnecessary. I wouldn't say unnecessary. I think it's important to rule out other problems, but the typical pathway of dealing with these atypical symptoms is to see an ENT specialist or an allergist or someone or a pulmonologist because you're having these ongoing chronic pulmonary symptoms, and not everyone thinks outside the box and thinks that maybe a silent or asymptomatic GERD, gastroesophageal reflux, is causing this. And it's not, on this slide, I should probably add it, but there's some symptoms that I call alarm symptoms. If you're having trouble swallowing, you feel like things are literally stuck in here along the route, or you have blood in your stool or throw up, or, anemia on a lab, or some combination of those things, those would be alarm symptoms. It could mean something more progressive is going on at that point. So you may want to move quicker to get a workup done. So this is why I'm passionate about GERD. As a surgical resident, I was fortunate to train in all things related to the abdomen and disease, and I was part of several cases related to esophageal cancer. And you know, the reason I'm passionate about this is, although I didn't go into surgical oncology or becoming a cancer doctor, it's very clear that there's a rise in esophageal cancer. And this is the trajectory from 1975 to about now, and where we might be beyond this. Although these numbers, overall, the incidence is still small because we're talking about cases per 100,000 people, but still, a sharp rise is a sharp rise. And believe me, you would never want to find yourself as a data point on this chart. Esophageal cancer is still highly lethal, and people who survive never really have the same quality of life ever again. So it's one of the harder ones to deal with. It's harder to survive, and if you do survive, it can be very life changing. Chronic pain, trouble getting nutrition, these are pretty commonplace once you have an esophageal cancer diagnosis. So this is why I want to act on this more aggressively. Also note, 25% of precancerous changes that were found in the esophagus, or frankly, 40% of people who had a cancer at the final time of diagnosis only ever reported minimal GERD or no history of GERD at all. So that's scary to me that you could be someone who really has no symptoms and you could be harboring silent acid reflux and having problems. And if you've been sitting on mild symptoms for years, hopefully this is a kind of an eye opener. So we'll talk about hiatal hernia at length later. It's what is a hiatal hernia? I'll point it out once we get to the pictures. I think here, two things that are worth saying. Generally, I think it's underdiagnosed and underreported. I think a body of physicians out there who have they're not clinical anatomists, which is essentially what a surgeon is. They maybe forgotten some things, some subtle things they learned about the barriers to reflux. A lot of physicians out there think hiatal hernias are pretty normal to have and don't contribute to your GERD, and that's frankly that's wrong. And it's important for you to know that it plays a big role, and actually they're safe to fix and easy to fix. And note that as we age, there's a high likelihood that we'll develop one. And also note that if you're overweight or obese, there is a high likelihood that you have one. And I actually think all these percentages are even lower than what they probably are in real life. Antacids have clearly created a revolution. According to NIH data, as far as all over the counter medicines go, that would be like, of course, antacids, but also your common cold flu drugs, your Tylenols, your Advils, Gas X, constipation related things. PPIs or antacid medications make up 85% of the over the counter medication use. So clearly, a lot of Americans are reaching for these things at a very high percentage. And this leads me to say something. If you think about it, when you're in a room, in a room with a group of people who all have the same symptoms, it's easy to assume that that must be normal. At one point in time, we normalized other behaviors that we figured out were extremely detrimental, like smoking. It wouldn't be that uncommon 20 years ago for every person in a bowling alley to be smoking, for your own doctors or nurses to be smoking in the hospital. And we realized after a few decades that that was not good, right? So I think we're at this point where we've normalized the behavior of having symptoms and masking them with medications. And finally, having done that for a few decades, we're realizing that there's a cost to it. Taking PPIs, otherwise known as proton pump inhibitors, which are the most potent antacids, has some real health consequences. For example, you can get deficient in calcium, which, if you're a woman and you're already prone to postmenopausal osteoporosis, this could increase your risk of a hip fracture by 35%. And there was a clear causal relationship that was determined where if women went off of their PPI, their bone density got stronger, the risk of hip fracture went down measurably. So, similarly, along that vein, the idea here is that when we suppress acid levels, realize some elements, electrolytes, and vitamins require that acidity to be absorbed properly and for cells to function properly. And so, when we're chronically over years suppressing our acid levels, we can get deficient in critical vitamins and nutrients. Also, acid is a defense mechanism. Having acid coating our GI tract helps fight certain types of bacteria that we don't want to colonize. One example is C. diff, which can get into our colon, and it's a leading cause of infectious diarrhea. You're at a 3 times higher risk if you're on a PPI for that one. Community acquired pneumonia, apparently 2 times more likely in patients who are on PPI. Acute kidney injury and also chronic kidney disease can happen with these drugs. So I think it took years of normalized behavior and, oh, my uncle and my uncle uses antacids, and so do I. No big deal. I know if I throw the Sunday night football party, I better put some Tums out on the counter. We're all going to pop a few and go to sleep fine and wake up feeling fine. But it's just the status quo. When I buy my wings, I'll buy my Tums. It's easy to think that that's a normal, healthy way of living when everyone's doing it, but it frankly is not. What are the mechanical barriers that we are born with? We have certain anatomy in place to help us fight GERD and GERD symptoms. One is the hiatus itself. A hiatus is simply a window or opening. So where the diaphragm muscle should wrap the esophagus, it should be a nice snug opening. And I'll show you how when you have a hiatal hernia, that's a dilated space. The lower esophageal sphincter, which I should put a star by this. Most people think that's the one and only barrier we have, but that, as you'll learn here, that's not true. And of course, the angle of His, I just call it angle for short, where better shown over here on the right, where the esophagus launches and takes off into the top part of the stomach, creates a nice angle here that can act as a reflux barrier with some specialized muscle fibers. There's also a ligament here, just like we have an ACL to hold our knee in place from sliding on itself. We have a ligament at the bottom of our esophagus and very top portion of our stomach to position and hold this stomach and esophagus in this position. This is where things work the best. So just like we would be upset and we would get our ACL fixed if we had an ACL injury. Unfortunately, walking creates pain, but digestion and eating does not. So it's possible to have a disruption of your ligament here. It becomes a stretchy, floppy rubber band instead of a solid tether cord. And unfortunately, we're not aware of this, or the moment we are, we're masking symptoms with a simple antacid. And so there we have a issue that goes underdiagnosed and underappreciated, unlike our orthopedic pathology, which is really harder to ignore. All right. Barrier number one is the hiatus itself. I told you that's a hole in the diaphragm to allow the passage of the food carrying tube, the esophagus, from in the chest to down in the belly. Should be nice and snug. It's worth pointing out that while most of the fibers of the diaphragm are in nice straight lines, very uniquely and I think very elegantly designed are these what I call lasso fibers. And the fibers of the right crus, the right half of that hiatus, come around, wrap around the esophagus, come into a nice tight bundle in the back, and come back together. So quite literally, when your diaphragm flexes down so you can draw in air and breathe, these fibers are kind of flexing in a circumferential or circular pattern to pinch the esophagus, which I think is so cool. I remember being a kid at a birthday party drinking, Coke and eating pizza and cake, and I could still go to the monkey bars and hang upside down as long as I wanted without throwing up into my nose and mouth. Thought of doing that now is a little daunting for more than one reason. But as you're listening to this, if you're already sleeping on multiple pillows, you need a recliner, you're really relying on gravity to keep things down in your belly. It could be because there's a disruption of the ligament. By the way, the origin of that ligament is the underside of the diaphragm, and you've had a disruption in the traction created by these lasso fibers. So you can see how this is a physical barrier. It's very nice to be able to take a breath and have these tighten down and not feel like things are going to well up and gush up into the esophagus. This is also why by the age of 70, I think we have a 70 or percent or higher rate of hiatal hernias. As we age, we undergo age-related sarcopenia. That means our muscles kind of waste away or get weaker and thinner. Well, the diaphragm is a muscle, just like any your quads or your biceps. We already do a poor job of exercise. So in a Western sedentary job, sedentary lifestyle, we don't go for enough runs. We don't train our diaphragm. We don't have robust muscle. And so you can see how that lifestyle plus aging leads to a high likelihood just with time that you're going to develop a big gap here. Whereas if you exercise and maintain robust muscle fibers and fight sarcopenia as long as you can, you may be less likely to lose this critical barrier. So you can see how that's tied to that statistic from earlier. Also important to note, a lot of doctors don't appreciate this, but half of the quote LES, which I already said a lot of people think is the main barrier, is actually from the diaphragm, the hiatus itself. So these two muscles need to work in concert to constitute a healthy LES, lower esophageal sphincter, which is the next barrier we're going to talk about. Here's the arrow showing that LES. I start over here on the right side. In a resting position, these internal esophagus muscle fibers are closed and pinched shut. When you chew and swallow, a nerve conduction signal comes down at lightning speed and tells it to relax and open so food can go through. That signal expires and it goes back to contracting shut. So this is very much a unidirectional valve, like a trap door, that should allow food to go through and then keep things from coming up. Well, I showed you some food triggers like chocolate or coffee. Red wine byproduct may do this too. Um, Certain chemicals can cause this muscle to abnormally relax and stay relaxed for prolonged periods while you're eating and after you're eating. And so that's where I tell you that while this muscle is under neurohormonal control, certain things we eat in our lifestyle can overcome that. Here is the best picture of the two components of the lower esophageal sphincter shown side by side and actually the ligament with them. So these are the lasso fibers from the last slide, and these are the internal muscles inside the esophagus. They need to be next to each other and held together by this ligament in order to function properly. When you breathe and take a breath, you want these fibers flexing right here in this area to better close that diameter down. And any disruption of this, even if it's not a wide gap, but suddenly this is flexing up here, that's a hernia that doesn't register as a hernia to our eyes, or if you're a GI doctor, that did your GI doctor did an EGD, they may not notice a gap here, but if these muscles are flexing below the other half of the fibers or above, it doesn't lead to optimal function. So, and specifically, I should correct myself. Flexing below the other half of the lower LES can lead to more of a problem than it can be a helpful change in anatomy. Okay, last but not least, the angle. These are some specialized muscle fibers that literally create a saddle here on the stomach. They extend onto the esophagus. So think of your muscle as having amazing function. It has muscle fibers that go directly across at an angle from top right to bottom left, and also in circles around the stomach and vertically. And so it can fire off these muscle fibers while you eat and digest to slosh things around and break things down. Well, smartly, we're designed with a few of those fibers that go wrap around the distal part of the esophagus and go straight down like this. And when they contract, you can see how they further narrow the diameter here and augment how well that lower esophageal sphincter works. So um, these fibers are susceptible to issues when they're not positioned in the stomach, or when these things get straightened out or put on stretch, they don't work that well, as you'll see in the next slide. And here's a hiatal hernia. It's worth noting that in appropriate position, normal anatomy, these lines never cross. But once you have a hiatal hernia, which technically is defined by a dilation here, the distance from this point to this point is clearly bigger here. It's not the best representation, but there's probably a doubling of the diameter of this hole from this side to this side, talking about going from the right cruce to the left cruce. And when that happens long enough and pressure in your belly is high enough chronically, contents of your stomach can come up into here, including the anatomy. So what can happen with a hiatal hernia over time is it's not just a widened space, but if you wait long enough, the LES can migrate up into the chest where it doesn't work well. It doesn't have its external component and friend, which is this muscle that should be pushing against it. And we have those linear angle of His fibers that are now drawn straight down, and we've completely lost that nice rounded angle here. So you can see how this is a mechanical problem. Again, by analogy, if you're someone who can't eat at night and lay down and things are coming freely in your throat or mouth, there's got to be some disruption here. I refuse to believe that it's an isolated the little muscles inside your esophagus are the only problem. There's something going on with one or two or three of these barriers. Note though, you can technically have GERD without a hiatal hernia, and it could be an isolated problem with just this. But overall, I think we over appreciate that that is the main cause, and usually there's other things going on. So here's the next steps. These are the tests I'm going to recommend we get done. They're called Esoguard, and EGD stands for esophageal gastroduodenoscopy. That's like getting colonoscopy for your throat, stomach, and esophagus. pH impedance, this is kind of the gold standard, actually. If we really want a definitive diagnosis that acid is leaving your stomach with a high degree of frequency and burning the bottom of your esophagus, that's the best way to do it. We also have esophageal manometry. Let's talk about each of these. Okay, Esoguard. Let me go ahead and pull up the QR code. If you have your phone, you can try to scan this and save the link. Relatively new. I think this will be commonplace here in the near future as an excellent screening tool for esophageal cancer or precancerous changes of the esophagus. Highlights here, it's free to you if you have insurance. If you don't sign up for this. It's we offer at least at the time of this recording once a month screening in our office, and I should have had you fill out a form that would tell us if you qualify. It's a simple 5-minute procedure where you swallow a thin catheter with a balloon at the end, and as they draw it back, the technician will brush a few cells from around that critical area, actually in the LES zone, which is where esophageal cancer tends to happen, and send it off to make sure you don't already have cellular changes that are worrisome. If it's positive, guess what you need, which I kind of want you to do anyway, is an EGD. But here's where things get tricky. Current standard is EGD, and doctors with varying level of expertise, understanding, and uh, and experience in visualizing abnormal anatomy who may look at your LES area and say that it looks normal. Most of the time, people don't even do a biopsy there. And in fact, when they've looked back at data, come to find out there was abnormality there and there probably was a precancerous change. If it looks highly abnormal, most of us will do one biopsy instead of doing several biopsies all the way around. And even then, there's a chance of missing the diagnosis. So I believe this test is going to be better in detecting those changes. And if it's positive, the way it'll help us is it'll especially make us focus during the EGD at that area. Go ahead and take more biopsies, and it can influence our decision. So that's how I think EsoGuard is useful. The next thing is the EGD. This is, again, like looking at the stomach and esophagus with a camera, much like you would with a colonoscopy. You do need a day off from work and a ride, but it's moderate sedation. You don't remember the process, but you'll be awake from that sedation and able to go home probably within 2 to 3 hours feeling completely normal, like it never happened. You don't need to do any kind of prep for this other than fasting after midnight. And this is to help us, again, when we come in here with a camera and look back, we can see hiatal hernias that maybe an x-ray would have missed. We can visualize that area again and send in these little biopsy forceps to take multiple biopsies. One of the main things I want to do is make sure you don't have certain pathology down here like ulcers or, God forbid, but a mass or something going on that needs to be addressed first instead of dealing with the reflux component of things. This is a view from inside. This is different grades of what we call esophagitis. This is what LA grade B esophagitis would look like. We're looking literally at where the LES is, and that cellular change happens from normal esophagus to stomach tissue. Shouldn't look like this. And if you have this or higher, technically you can skip the pH impedance study, at least as it relates to getting a links. And so this can be valuable information. And this is the zone from which we would take ideally a few biopsies if we saw this. So that's the EGD. pH impedance, again, gold standard, best way to diagnose and determine that you have a true acid reflux predominant GERD. Um, it involves placing a tiny little Bluetooth device about the size of a pencil eraser at the bottom of the esophagus near the LES, and actually technically above it. So we know that when things leave and cross the LES barrier and come up, that's when you have GER, gastroesophageal reflux. Data from this is transmitted to a monitor that you either carry in your pocket or clip to your waist belt. And the suction here lasts about 3 to 4 days, and then it releases itself and it passes on. You do not need to collect this from the toilet and return it. It passes through without you being aware and painlessly. But the data, then after about 3 or 4 days, you'll return this device, which they'll plug into a computer and give us a spit out like this. Actually, we get a calculated score called the Demeester score, which if it's high enough, it means you truly have gastroesophageal reflux with acid. Again, if you have those EGD findings, we may be able to skip this, but hopefully one of the colleagues I'm sending you to combines placement of this with the EGD so that they can look and decide if you need it or not. Um, that is that study in a nutshell. Um, you can scan this to go to, I believe, a YouTube video or a website link that goes into more detail about how it works. and what we're hoping to gain from it. I want to also add it may be important to keep a journal while you're having symptoms. If we see spikes in acid at the same time you actually felt something, I think that's very powerful. Last but not least, esophageal manometry. This is an uncomfortable study. If I send 10 people for this, you know, 9 people will finish it. One person will kind of say, it's too uncomfortable for me. And that's okay. No one's going to force you to do stuff. But to be honest, if we're going to offer the links and have the most definitive information on what's best for you, this is an important one. So a catheter is placed that measures the pressures in your esophagus while you swallow sips of water. And it can tell me if you have disease of your esophagus, like it's just functioning irregularly. And that could be a reason you're having symptoms that we mix up for true acid reflux. And it would be wrong to do a surgery sometimes. So highly valuable information. Again, 9 out of 10 people can finish it. So I believe you can. But 8 or 9 out of 10 will say never sign me up for that again. So it is uncomfortable, but I believe in you. I think you can get it done. Um, and we kind of need it to fully consider all the options. And it's going to tell us how strong your esophageal contractions are. Can you clear food from your esophagus? Especially if we place a device at the bottom of that, I want to make sure you can push through. Here's a QR code for more information and a helpful video on how that study works. So briefly, I do want you to know that surgeries, they're now being performed with a very high success rate, 80 to 95% chance of improving your symptoms, greater than 80% chance of coming off that PPI forever. And in a worst case, some years down the road for long-term follow-up, we did find that some patients needed to go back on them. But then again, I always wonder, what's that patient done for themselves in terms of lifestyle and maintaining their weight loss and other things. So without a doubt, lifestyle change needs to happen now. If you're seeing me, um, while PPIs are a band-aid to the acid reflux, that's tolerable. I personally wouldn't recommend trying to use surgery as a band-aid to ongoing potentially abusive lifestyle. I think once you have a surgery, you've undergone the cost, the risks. You want to do what you can to preserve that and make it last as long as you can. So keep that in mind. That's this first picture is a picture of a hiatal hernia repair. Briefly, we may or may not use mesh. Here's a picture of the Lynx device, magnetic beads that help that lower esophageal sphincter close when food passes through and prevent acid from coming up. And then lastly, a fundoplication. That is the traditional way of doing anti-reflux surgery, whereas we now have metal beads. We used to use the top part of your stomach to wrap around here to help it function better as a barrier. In summary, I think you made the right choice, at least being open-minded and coming to hear about your options. Hopefully, you understand that the grave consequences of not treating GERD or long-term treatment with medications that have side effects. You now understand how you have barriers to reflux, and that we're going to send you. That's the next step is to send you for testing to see what part or parts of your anti-reflux barriers or GERD barriers are intact or not. And then the next time we'll learn more about these surgeries and hopefully select the option that suits you best. Again, I hope we accomplished our goal of empowering you and educating you. Um, I'll be with you shortly. I look forward to getting to know you and answering your questions. Thank you.